Hi, everyone. I'm Jack Cush with Room Now. Welcome to the EULAR 2023 Daily Recap. It's day 3 here in Milan, and I have with me my friends and colleagues, and we're going to discuss some of the highlights of today's meeting. During this session, we're going to each review about 2 of our favorite abstracts, have the discussion on the impact of this data on practice and what we currently know about those subjects. And let's begin. I'm Jack Cush with Room Now from Dallas, Texas. Antoni?
I'm Anthony Chan. I'm from London, United Kingdom.
And Yus?
Hello, my name is Yusof. I'm a rheumatologist from Leeds, United Kingdom.
All right, so we are here in Milan, although right now we hustled back from the meeting to get to our hotel room so that we could do this Zoom recording for you. Yus, why don't you start us off with what you thought was a highlight from today?
Yeah, so I would like to highlight about some of data from SLE trials. I think it's been quite exciting. The past 2 days, we had data pertaining phase 3 positive results of telitacicept. We also had positive phase 2 results of upadacitinib and also ianalumab. So on day 3 today, so we had a first-in-class therapy called pozomib. Yeah, it's quite difficult to announce. Sounds like bortezomib. So the poster number is 1128. So this is a smaller scale phase 2A study. So zetomipozomib is an immune proteasome inhibitors. So it acts on quite diverse cells, both innate and adaptive immunity, working on macrophage, B cell, and T cells. So in this trial, so they are looking in terms of patient with active lupus nephritis, grade 3, class 3 or 4, plus minus 5. So the primary endpoint was 50% reduction in proteinuria. So they recruited 17 patients, and at 26 week, just over half of the patient met the primary endpoint. And when they look a little bit more detail in terms of a higher hurdle endpoint, which is the complete renal response, which usually defined by less than 0.5 gram per day proteinuria, plus stabilization of creatinine or eGFR and reduction of steroid less than 10 milligram per day. So this is also quite good. It's about around 35%. So one thing that people are asked about, if it's a proteasome, some people are concerned that potentially, treatment with bortezomib, for instance, because it acts on the plasma cell depletion, whether this could lead to low IgG and serious infection. However, when I spoke to the investigator today, they said, it doesn't, act on the plasma cell depletion. Hence, in this small study, there were no low IgG and serious infection recorded. So it's still early. So they're now recruiting for phase 2B study, which is slightly larger. And hopefully if there's a more promising signal, they will then proceed with phase 3 globally.
So this is a very early study. It's open label. It's 17 patients. It's so those are encouraging. It's an encouraging start, but what can you realistically take away from this, other than you want to now see phase 2 data? Was there anything else about the study that gives you new hope for this slightly different or new mechanism of action?
Yeah, I think right, Jack. Yeah, it's the new mechanism of action because it acts both in innate and also adaptive immunity. So I think it is a new thing compared to the one that we've got so far from the voclosporin and belimumab for the lupus nephritis.
So are you? I want to get you. You're a lupus guy. You do a lot of lupus research and you're knowledgeable about these trials and whatnot. And I'm a rheumatoid guy, and I look at the lupus data, and I'm just always a little disappointed because I have great hope in phase 2 where things look good, but then things sort of never look as good, and the drugs fail in phase 3, like for instance baricitinib or ustekinumab. Where is the trip up? Is the trip up in that the outcome measures don't allow them to succeed? Is the trip up that they're going for a general lupus indication as opposed to what these folks look like they may be going after, which is a smarter, easier, more direct lupus nephritis indication? What would be your advice going forward in developing trials like this?
Yeah, so I think probably much all of the above that you mentioned, Jack. So I think the problem with clinical trials before, like a decade ago, I think a lot of problem with the trial design, especially the inappropriate use of meaningful endpoints, which we have now improved and we have learned from our mistakes, and also the use of active comparators. So I think in the past, we used really high dose steroids, so that's why we got really high placebo response. Whereas these days, for example, when you try like voclosporin in lupus nephritis, you can see they started on 25 milligram daily of prednisolone, and by week 16, everyone below 5 milligram per day. So because of that, they can minimize the the placebo response there. So I think these days, even the composite endpoints, apart from like SRI-4 or BICLA, most recent trials that currently become positive, they also included reduction of steroid as well. So I think a cause for optimism there.
Antoni, what do you think of this kind of research? Is it helpful to the rheumatologist?
I certainly think so. I think we need certainly a lot of new therapies in conditions like lupus and Sjogren's. I remember from the last meeting, this was very much in development. It's good to see that this has come along, but again, small numbers. And I think the patient selection is going to be quite important because with lupus studies, antibody positivity, has a strong impact on how these patients may respond.
True. Okay, so Antoni, what's your favorite one from today?
I've had a great day looking at rheumatoid arthritis and also JAK inhibitors. There's a lot at this meeting coming on the back of oral surveillance. Numerous posters and abstract, but the two that the main one today was the jackpot study. That's OP219, which is a composite of 14 rheumatoid arthritis registers, 50 over 1,000 patients. DAS28 score, active disease 4.1 to 4.7 across the TNF, other modes of action, and also the JAK inhibitors. And the reassuring data was the incidence rate per 1,000 patient years came out at 1.76 for JAK inhibitors and 1.86 for the TNF inhibitors. Now, of course, these were not particularly enriched populations compared to the oral surveillance, but in the general population, the patients that we treat with rheumatoid arthritis, this signal is reassuring for us. And also, subsequent to this, there was a Dutch group that also published very similar things today. That's OP221. So I think this, in terms of clinical practice, doesn't stop us from still assessing our patients carefully. The older patient above the age of 65, the smoker, cardiovascular risk, but at least I think it just allows me to consider in those patients who perhaps have used many of the other drugs that JAK could still be a possible treatment option.
Yeah. There are a lot of studies, as Dr. Chan points out at this meeting, that are designed to answer the question, was oral surveillance and its takeaway messages real? Should we really worry about that? Prior to oral surveillance, all of the studies that examine the issues of cardiovascular risk and cancer were negative. And they were just like this. They're registries, they're long-term extension studies, they're meta-analyses, they're reanalyses of the original data set that got the drug approved where there was no signal seen. But that's why the FDA required a post-marketing regulatory requirement to do this phase 4 safety study called oral surveillance, which, by the way, was a 4-year, 4,500 patient with randomization, blinding, endpoints, really clear questions to which it gave us an answer that we can argue about as we have for the last almost a year and a half. But now we got all these reports like Jackpot and the Dutch study and the Korean study from yesterday. And I see at least 3 or 4 others that basically take large data sets and they reconstruct their data set so it meets the enrollment criteria of oral surveillance. They had by age and by having a cardiovascular risk factor. They don't necessarily recreate disease activity that was seen in oral surveillance. And they don't necessarily recreate, what prior therapies they had failed to get to where they were. So they're not going to be the same. And they just read out what happened. The problem is a lot of them, I'm sorry, I'm going to go off on this because I obviously have an opinion, but they don't have the exposure of 4+ years of the drugs that we're talking about. And we know you need long exposure on JAKs and TNFs to get a benefit on cardiovascular event reduction and maybe even on malignancy event reduction or modulation. And I'll point out that the Jackpot study, which was, as you said, 15 registries from all over the world, actually have 20 registries, and they're going to complete their data set. They had an admirable effort that basically showed no difference between the JAKs and the TNF inhibitors, but it suffers when you ask the one big question I asked, which is, in this study, Jackpot, they took the patients who were on JAK inhibitors and TNF inhibitors and OMAs, other mechanism of action biologics. And they had 3 large cohorts, and they followed them forward, and they compared them. In each of the cohorts, they had between 12 and 20,000 patient years of exposure, which was really more than about 2 years of exposure. But even with that much exposure, the number of actual cardiac events was 60 to 80 per group. That's incredibly low, very, very low, to the point it almost negates the effect of the study. And when I asked that question of Dr. Romain Orion, who did a great job and did a lot of work on this, he didn't really have a good answer. And he basically said, these are the limitations of registries. You don't know how they're getting to where they get. They don't all fill out the same form. Sometimes these are handwritten in narrative notes as opposed to check boxes on there was a cardiovascular event and scoring of it. So this is the limitations of what you get. And when you have these analyses that are designed to look like oral surveillance, I'm just going to say they're not oral surveillance, and hence they can't really stack up. You want to really show that oral surveillance wasn't right, then you're going to have to spend a lot of money, a lot of time, and who knows, maybe if oral surveillance was done again, it may be just like the gout studies with febuxostat. There are 4 studies with febuxostat that ping pong back and forth as to whether febuxostat or allopurinol has a greater cardiovascular risk. And what's the real story? Patients with gout are a mess. They got lots of inflammation. They have high event rates. They're all going to get renal disease and diabetes and heart disease. And, it's just a mess. And so it's a roll of the dice when you do a 5,000 patient trial over 20 months as to what may in fact happen. And that's in fact did happen with starting with the confirmed study and ending with CARES and the last one that was just done in gout. I think the same thing would happen with oral surveillance. If we did it again, it might give you a totally different result. But you're nonetheless stuck with the results of those studies. And the story we're telling ourselves as rheumatologists may not be the right story, because you want to kind of stick to your guns on what you're doing when the data really is dictating, as you know, with the EMA and with Canada and with the United States and the FDA, they've changed the rules on JAK inhibitor use. We have to live with it. Yus, what do you think? You're also in the UK. How do you look at this kind of data?
Yeah, so I think, echoing to what you said earlier, I think, once recently we've received like notification from the EMA that we have to be, cautious on these patients, above 65, had a history malignancy and also VTE. So in terms of the practice-wise, it does impact, the prescribers. Like we start to think, and so before this, when the JAK came out and everything's like good and wonderful, and now we are slowly getting more cautious, and we start more personalized treatments to those people, patients who are not on those categories. So like you say, time will tell when we have more further follow-ups that we can justify this reversal of EMA mandatory notification.
Mm-hmm. Yeah, Anthony, what would your advice be as far as how we can look at data that may make us feel better about JAKs? Do you think that registries like this are the way to go, or is there another way? I don't know if there really is another way other than spending the money to do a really large trial.
Yeah, I think we registries are useful, but they suffer from recording issues. We may not always record everything that the patient has, and also the effect of, if we start putting out these warnings, we will get a channeling bias. So we will start putting people with very low risks in the registries because we've been told not to use this in a particular group. So the registry itself may not actually pick up when prescribing patterns have changed due to either rules around the use of the drug. And this goes back to the question about understanding the methodology in oral surveillance versus the registries. But, we have to make the individual discussion at the end with our patients as to, how suitable or how safe they are to go onto a drug like this.
Yeah, the one, while I may have overly critiqued this tremendous effort that they've made here, I will point out that the great point that Dr. Arian made was a lot of the registry data that was recorded was in fact recorded before the results of the oral surveillance came out. So while the registry may have been faulted across the board for its reporting, maybe underreporting, at least it's consistent across the 14 registries and the 3 classes of drugs, and their end message may still be exactly right, that there was no difference between these 3 classes of drugs when it came to MACE events, and whether we need to worry about that when we choose a TNF inhibitor, JAK inhibitor, or a biologic that has another mechanism of action. So that the end message may be still the same, albeit for some of the faults of the study rather than some of the strengths of the study. I don't know. Yeah. Anthony, were you going to discuss the rheumatoid factor paper from Austria, or do you want me? Is it okay if I talk about that?
Yeah, go ahead with that. In fact, I had another one separate to that one, so
okay.
you can go for
so,
that one.
Dan Alataha's group presented an interesting report that I don't know what to do with, and maybe my friends can make it clear for me. It was presented by Victoria Consett, and the title was "The Early Response in Rheumatoid Factor Levels Predicts Subsequent Clinical Response on DMARDs in RA." The bottom line here being that they took a 2,000 patient RA cohort and followed them with repeated clinical measures of outcome and efficacy, things that you normally do. But they also did repeated rheumatoid factors. I wanted to ask the question, but you're limited in questions these days. Why did they hang their hat on rheumatoid factor here as opposed to ACPA, which seems to have more impact on activity, worsening, etc.? But nonetheless, they looked at rheumatoid factor potentially as a biomarker in this Vienna rheumatoid arthritis cohort. And what they tried to say, was, can you look at rheumatoid factor as an outcome measure if your outcome is that rheumatoid factor goes down significantly or becomes negative? So a drop of 50% or more, or converting to seronegativity, you are then called a rheumatoid factor responder. And this was across the board, looking at many different drugs. They didn't give you any drug information. I found that somewhat disappointing. They did say that there was very little rituximab in play on this. I found that to be useful and helpful. And when they looked at the patients, going rheumatoid factor negative, the number was something like 30% by 6 months became rheumatoid factor negative. Now, what I have a lecture on seropositive, seronegative RA, saying that there are only a few drugs that really lower rheumatoid factor: rituximab, abatacept, and JAK inhibitors. TNF inhibitors don't, IL-6 inhibitors do not, and they included conventional synthetic DMARDs, methotrexate, leflunomide, etc. We do not think of those as lowering rheumatoid factor, but yet in their cohort, 30% of their patients across the board had a drop in their rheumatoid factor, and that predicted a better outcome. They then wanted to say that, what if you considered this like a treat to target measure? When they did a comparative analysis of different treat to target measures, they said that SDI, the Simplified Disease Activity Index, that is tender joint count, swollen joint count, what is it, PGA and Physician Global and CRP. CDI does not have the CRP. SDI does have the CRP. That the CDI was a better predictor of achieving a low disease activity state, but not be far behind it was this, the rheumatoid factor responder. With, if you were a rheumatoid factor responder, you had a 13% greater chance of getting treat to target or getting to LDA. Now, that's significant, but is it big? I don't know. She didn't tell me how big the SDI response was, and she couldn't tell me what would happen if we just applied the same rule to CRP. So the question is, based on this data, should you, Antoni, and you be doing rheumatoid factor quarterly or every 6 months on your patients and using this as a biomarker? Are you really doing something important and smart? Are you driving up the cost of care needlessly? And again, they only looked at patients who were seropositive, who had moderate to high disease. You don't usually start out thinking patients based on their DAS score and where category they're in. And would you not be applying the same thing? And then the other question is, as John Giles asked from the microphone, is this lowering significant when you go from 40 to 20 in rheumatoid factor as opposed to going from 400 to 200? And again, no answers were had. So I'll now pose the pithy question to my colleagues. What would you do with this data? Or so, Antoni, what would you do?
I think yeah, a very nice presentation from today. I don't think we understand the scale of this. Firstly, what percentage reduction does this impact? This has to be very high before we can see an effect. And secondly, the effect of the drugs. Are you measuring the effect of the drug, or is this part of disease? The same argument we had with the IL-6, with the effect on CRP, and then using DAS CRP as a measurement perhaps was not as a good marker when there's a biological effect on the very thing that you're using as the measure. Would that also, rituximab, for example, I know in the study they said small numbers, but if that affects the rheumatoid factor and may not necessarily affect the disease, we don't really know that. We don't serially measure it, so this would result in a change of practice if we were to go this way. And could there be a better way, as you say? Could it just be just as good to measure CRP, which is what we're doing now, rather than to go for this? And would the same be for ACPA? So we have always used this as prognostic factors, prognostication, rather than as a treatment effect. So this changes it if we are to go this way, and might drive up the cost. But if it does, then it might be cost saving in the long term. You could say measure it for the first 12 months, and that would be a measure of the efficacy of the treatment that you're giving the patient.
I must say, in my teaching over the years, when rheumatologists are using serial serologies or doing serologies at every visit, I usually yell at them saying, what are you doing? That's kind of stupid what you're doing. Or it's greedy, meaning you're doing it because you own the lab and you're just channeling business into your own lab. But there's no good reason to do that repeatedly, because generally these titers don't change, or seropositivity is to go into seronegativity is an uncommon phenomenon. Although when it happens, it's good. There are reports showing that it's good. But again, why do that? So I'm kind of feeling guilty about being so hard on my colleagues and my fellows about doing serial serologies. But what do you think of this data?
Yeah, so I think interesting that in the study that only less people were on rituximab. So we do a lot of studies in B cells and rituximab in leads. So what I've did analyze some of our early cohorts of rheumatoid arthritis treated on rituximab. When initially I tried to derive like a model prediction that that we can use to predict response and relapse. So the initial cycle, I mean, this is the study that we presented in EULAR a few years ago, but I didn't get around to formally published it because I think it is complex. I think, you know, to do a modeling in rheumatoid arthritis, the biomarkers is quite complex compared to other diseases. You know, I must say like lupus is actually potentially quite easier than rheumatoid, you know, treated rituximab. So what we found in terms of the predictors of, you know, poor response, if you have a higher disease, you know, DAS28 score at baseline, if you have a higher plasma blast, which we measured using highly sensitive flow cytometry, you know, in leads, and also high titer rheumatoid factor as well. So actually, when we measure it, the first cycle, so basically, if you do have, you know, we measured.
Oh, we have a hang up. He's leaving us in suspense. If you measure, okay. So user's going to have to come back in.
Yes.
Are you there, Yus? All right, let's go around. Let's do our second round of abstracts. Antoni, what's your next one?
The next one was also a nice oral presentation. Was this is on glucocorticoids, and this was about bridging therapy at the start of treatment, 35 weeks of glucocorticoids, and that impact on the long-term. Firstly, the long-term use of glucocorticoids, and secondly, whether it had a long-term effect on outcome measures DAS28. And they found that those who had bridging at the start tended to use more glucocorticoids in the first 12 months. They got better response at 6 months, but after that 12-month period, they equal out between those who had the bridging and those who didn't. So it kind of comes to the question: should we be using a lot of these glucocorticoids at the start of treatments in our patients? Because it seems like there was no real difference after the 12 month, although they did say that they had a fewer DMARD changes longer term if they had bridging therapy with glucocorticoids.
Did they look at stopping steroids in these cohorts?
Yeah, they did. So they tried to stop the steroids at 12 months, but they tended to stay on them for longer if you had the bridging therapy compared to those who didn't.
So that's the argument here that, you know, if you steroids are great, but are you going to stop steroids? My main rant right now is the great quote from Peter Merkel that steroids are the best drug we have, the worst drug we have, and that you shouldn't use a steroid unless you have a built-in expiration date. I'm going to give you this drug. I'm going to give you this drug for 10 weeks and only 10 weeks. Otherwise, you're dealing with the consequences of steroids being the easy answer to any hard question you have in management. And I like this data, but it sort of works. And I think this data is true about what people really do. But at the same time, that doesn't make it right. And there's a report tomorrow from the Mayo Clinic group. There's a report tomorrow from the Mayo Clinic group, but also about use of steroids chronically. And it looked at 2 different eras and showed that the more recent era, you would think with more aggressive therapies being made available, that there would be less steroid use and less steroid continuations. But in fact, you know, if you look at, I want to say 2000 to 2008, and then compare 2009 to 2018, steroid use went up. They were not statistically different, but it went up. And then even worse was the fact that elderly patients were more likely to be starting steroids. Elderly patients were also more likely to be not stopping steroids. So those are people you don't want on steroids, but yet they're more likely to get them and then stay on them. And then even though we have all these drugs, in the second era, the latest era, 30% of patients are still taking steroids in spite of being on other therapies. This is all the Mayo Clinic data, and they're basically saying the same thing, that should you be rethinking your your strategy. Again, both Antoni and Yus are practicing in the UK and are a little bit more familiar with the EULAR guidelines on RA management. And I'll tell you, my looking at those too, I want to hear what you guys think about the EULAR guidelines and the steroid data. But the American guidelines from the ACR say, don't use steroids. If you do use steroids, you got to go off steroids. But don't use steroids. Did I tell you again? Don't use steroids. I mean, it says it over and over and over and over again. But when Dr. Smolin presented the EULAR guidelines last year at this meeting, he did like almost a 15-minute presentation. 9 minutes of it are why you should be on steroids and why it's okay to start on steroids, and then have the goal of stopping steroids as soon as you can in the future. So it seems that the EULAR guidelines are more permissive, that the paper that Antoni, you just presented are more permissive. The Mayo Clinic data shows we are being permissive, although I think their slant was they didn't like it. So how do you guys deal with steroids in RA patients in your practice? Not use them, only use them a little bit, or like using them?
We only use them for a little bit, and have an expiration date. Very important. So we give them not more than 4 to 6 weeks while we are, starting them up on their disease-modifying therapy. There is still a tendency to use them in people who are older. That's because of the monitoring, and they don't require sort of regular blood tests, and it's hard to get them done in that population. I think that's why these choices are made, but they are, not without risk. I remember your poster that you made about scary steroids. So it's something that our medical students look at and think maybe we should be considering newer therapies for these patients.
Right. Yus, what do you do?
Yeah, apology earlier. I've got a cutoff in the hotel, so I think just to answer to my conversation before, I wouldn't advocate repeating rheumatoid factors. So I think that from my opinion. So in terms of steroids, so we use intramuscular steroid quite a lot in the beginning when you first diagnosed. Then after that, in patient with like severe disease, we do, give oral prednisolone on top of the intramuscular steroid. But like Antoni was saying, we do have expiry date, so we make sure like we taper down, once they're more established on the DMARDs. So yeah. Mm-hmm.
Well, I like the idea that the intramuscular steroids really come with an expiration date. It's not like they can continue to take it or continue to abuse it, which happens with an oral prescription. Yus, do you have a second shorty that you want to present?
Yes, sure. So I know we talked about Jack earlier. I thought I was trying to stay away from it, but actually I've prepared another presentation pertaining to Jack, but maybe for a bit more positive spin. So it's an oral presentation, OP0225. So this is a study trying to see the efficacy of adjuvant recombinant herpes zoster vaccination, the Shingrix, in patient treated with upadacitinib. So essentially this a trial from Select Compare trial. Following the initial trials, they went to the long-term study. So what happened, so there were 95 patients were treated both on upadacitinib plus methotrexate, because obviously we think like if you have like dual combination, they may put increased risk of herpes zoster reactivation. So in this study, so these patients were given 2 courses of the Shingrix, one at baselines at the point of the long-term extension, and then they check the marker for cellular and also humoral response at 4 weeks after that, and then at 3 months they give another course and check another a marker of the response as well 4 weeks later. So the outcome, the endpoint is at that 16 weeks really. So what they found in terms of cellular response, so patients who were on upadacitinib and also methotrexate, the initial one, the first course, so about 64% people had a positive response, and then after it increased to about 88% after the second dose, and also the cellular response, so overall overall, there are about 2/3 of the patient had a cellular response. So this is in terms of the both cellular and also humoral response. How about the clinical implication? I think that's the most important thing. I know it was like quite a short follow-up, so they didn't find any herpes zoster reactivation during the observation, and importantly, only 2 out of 95. So I think that's probably about 2% people had a flare-up of rheumatoid arthritis, post vaccination. So I think this is really crucial data, and will give us, sort of assurance in terms of, like, in the short term after we give the Shingrix, that it can actually prevent people from getting herpes zoster vaccination.
Yeah, this is really interesting, and it's very germane. I use a lot of JAK inhibitors. I don't write a prescription for a JAK inhibitor unless I'm writing a prescription for Shingrix at the same time. Do I give them the same time? Do I have to wait? I don't. If the patient's already on a JAK inhibitor, I'll go and get the Shingrix. Ideally, I'd like them not to be on it. This study that you report, which shows pretty good results as far as responsiveness, 80% plus humoral response, 66%, cell-mediated immune responses. It's good, but it's not as good as the normal population. And the problem is they're on methotrexate, which is the one drug, along with rituximab, known to screw up all immune responses with vaccination. Doesn't matter which vaccine. It blunts it tremendously. So you're really not left with information, since everybody was on methotrexate and on a JAK inhibitor. You're really not knowing what to do with the JAK inhibitor, per se. The answer to the question, you want better responses, don't be on methotrexate. Do the PARC thing of holding the methotrexate for 2 weeks or 1 week based on more recent data, and then restart it after, at least 1 week later. But I think that they need to do this kind of research again, this time with controls and with a population that's not on a background of methotrexate. It was convenient because it was an extension of, you said, the Select Compare study. So I thought that was pretty interesting, but it still is instructive. I think this does help us, inform us. But you're still left wondering, do I have to stop the JAK inhibitor or not? Based on no data, or I shouldn't say that, based on my interpretation of available data, I don't hold a JAK inhibitor when I'm giving Shingrix. I don't hold a JAK inhibitor when I'm giving influenza. I didn't hold a JAK inhibitor when I was giving the COVID virus, even though the ACR later came out a little bit too late, I must say, and said you probably should hold it. That's based on expert opinion and not really based on any strong evidence, but we're still learning. And remember that vaccination is about risk reduction. So these things are never going to be 100% correct. That's one of the great things about the COVID and the Shingrix vaccine, is that they're 90% effective, but they're not 100% effective. And then how you use them, the circumstances and all that, who knows what may happen. But this data I thought was pretty encouraging. I want to present just a really quickie on infertility amongst men who are who have inflammatory arthritis. This is a study of 10,000 men from Norway, and it was presented today. I must say I was a little disappointed, thinking I was going to learn a lot in this thing. I didn't learn a lot, but they basically had 2 populations that they looked at, and they looked at infertility in several ways. And these are men with arthritis and autoimmune inflammatory disease, and they looked at fertility as being measured by how many children each man had, and the arthritis patients were compared to a much larger control group, and it turns out that male patients with arthritis actually had more children than did the controls. The controls 1.7, the patients 1.8, and that was highly significant. So yeah, they're fertile. Congratulations, whoopee. But now it gets confusing when she looks at the percentage of men who were childless. And well, shouldn't it be that since they're more fertile, that shouldn't be the issue? No, that has to do with want to get pregnant and tries to get pregnant, and as opposed to can or cannot get pregnant. And it turns out that being childless was much more common. Was more common in the controls and less common in patients. Controls, 27% were childless, and patients were 21%. So I guess that goes along with fertility. But if you look at those percentages, the number of people who are getting childless went up each decade, but the relative proportions were the same between the control group and the control group being the non-arthritis patients. And I'm looking at these numbers. I think I just got that wrong. The comparison group. Okay, so let's go back. Fertility measured by how many children they had for each man was higher in the arthritis patients, but being childless was higher in the arthritis patients. And I didn't know what that meant, but since the percentages of childless went up by each decade, and it really got even more significant in the last decade of 2000 to 2021 with greater spread, I think that means with greater availability of drugs, men with arthritis, especially biologic drugs, are more reluctant to get pregnant. And whether they're reluctant or whether their female partners are reluctant to have a child from a man who's taken some crazy dapaguzumab that nobody can pronounce. Lord knows what it does to your loins and whatnot. I think that and I know this from other studies that I was involved in with fellows at our center at UT Southwestern. When you ask women, they have a whole lot of fears about their ability to conceive, whether they should conceive, and whether they could actually have a normal, healthy baby in the future. And this diverts them from having children, having families, getting married, staying married, and these are conversations we don't have. So I don't know, you deal with this probably more in lupus patients. Is this something you discuss?
Or to the men or to the female?
Well, when you're women, let's say, but certainly I'm certain none of us are discussing it with the men. Now we have some information, but how do you handle these issues with women? Do you bring it up? Should you bring it up? Should you be better at bringing it up?
Yeah, we do. Yeah, so in our clinic, because I do both lupus and Sjogren dedicated clinic. So I do discuss, because their peak age of onset is between 20 to 40 years old at the most reproducible age. So we do discuss about fertility and also for instance like in Sjogren as well. We ask about intercourse, vaginal dryness and so forth. And I'm really frank with and open to my patient to discuss about this and to support them as well appropriately.
I would expect that, especially since you have those clinics, female dominant, many of them being of childbearing age. Antoni's really an expert in spondylitis, so he sees a lot more men. Antoni, yeah. I'm not even going to ask you whether you discuss this with your men. I want to know how you're going to handle this in the future when you talk to men who may want to get pregnant.
Yeah, we do discuss about this. Clearly, it's more for them about their pain management and their pain control, and how active they are in the context of all of life planning. But also interestingly, the whole question about in the rheumatoid, particularly the male patients on methotrexate, which again there was an interesting presentation today about how the fallout polyglutamate synthetase activities reduce in the sperm, and therefore reducing the methotrexate or polyglutamate levels, and perhaps suggesting that it's a bit safer than what we've been brought up to think, that you have to stop the methotrexate before trying. So I think there are a lot of things like this, that perhaps influence some of the decision making for people who want to try for family.
Yeah. All right, gents, this was a great discussion. Thank you so much for your time and your insights on these really interesting abstracts from EULAR 2023. To our audience, please be sure to tune in tomorrow. Dr. David Liu and Bella Mehta will be discussing their favorite abstracts from the last day, day 4 of EULAR 2022. Tune in to Room Now.